as civil society, we look at health as a public good, as a right. It's not a commodity.
A right to health basically means, are you physically, mentally, socially? Are you well?
In a system where states are working towards realizing the right to health, governments would ensure that everybody has access to good quality healthcare, regardless of their ability to pay.
And we're now currently in the process, and we're very excited about this, of rolling out universal health coverage in Kenya. So we have it in 4 pilot counties, but it's going to go to all 47 counties within the next year.
A lot is being done through universal health care. We have now a policy trying to make health available for all.
It is a really instrumental time to work with the government as they develop their strategies, as they review the pilots, as they plan their next steps.
In fact, as we speak, we are going to do our own audit as civil society in the 4 counties, just to understand really, is it helping? Have people benefited from it?
As we speak today, our systems are actually overwhelmed. It has really exposed, the weaknesses and the contradictions within our healthcare system.
The main thing that we're advocating for a rights-based approach to the pandemic and its response, focusing on the response and how it's going to affect different populations and what the government needed to do to center rights in its response.
COVID has made a case for the urgency of UHC itself, especially with the unique element about the COVID-19 pandemic is that no one is safe until everyone is safe.
We've gone through a very evolutionary way of considering health. So when we became independent, we wanted to be free for all. It's a basic thing. Everybody must have health. By 1988, we had user fees everywhere. Because we didn't have a Bill of Rights, it was always up to the government, the executive, to determine when they want to give you or not want to give you. You have nothing to rely on to oblige them to give you.
Human rights people, when you're writing our Constitution 2010, put it very clearly. And access to health should be given to everyone, without even finance being a barrier.
Having the Bill of Rights kind of gives us the basic framework for saying, this is how we're going to engage in our discourse. These are the rights that we have. This is your obligation. Now, what are you doing towards what you're supposed to be doing?
I've seen the counties where it's being piloted and people are very happy. In Kisumu County, I come around that side, and talking to people say this is it, because the barrier, especially financial barrier, is a big issue here, has been eliminated by this.
They say it's free. I'm yet to really confirm that it's free, because I've talked to a number of women and they tell me anytime they go to hospital they have to pay for 1, 2, 3 things. Then another thing is we have a problem with the human resource for health in the country. We do not have enough doctors, enough nurses to deal with the numbers that come. And that is the conundrum that the government has not been able to deal with from the time they introduced this kind of program. The pilot project is actually financed by World Bank. So that means the government has not injected in any funds. And so at the end of the pilot, what shall we be talking about? Where are we going to get the monies? We have a broke government anyway. So until that time when we're able to have a proper framework, I think for me, universal health coverage will be a dream that was never achieved.
there are significant amounts of problems when it comes to loss of funds. So the bureaucracy in moving money from government to individual facility is problematic, and it's been a huge challenge, such that facilities would rather charge you for every implement they use because they know they won't be able to get the money back. So even when they do charge you, like they charge you, it has to go back into a kitty for the government. And then there's no guarantee that it's going to come back to you because the kitty is the kitty. So just addressing the bureaucracy in the movement of money will be the first step. Another aspect is definitely addressing the leakages of funds and the corruption. We're not strangers to the fact that we have corrupt systems and we have a lot of money that we're losing through corruption. And we're now currently in the process, and we're very excited about this, of rolling out universal health coverage in Kenya. However, if we still have the same corrupt system, with the same bureaucracies, with the same leakages, it might just be like if you have like a mound of mess and then you put something over on top of it and expect the thing on top of it to be fine and just ignore the mess. That's basically what we're trying to address. Having a more accountable framework in the health sector such that when UHC is rolled out, it's actually meaningful for the people of Kenya.
Our work focuses on the international human rights law framework. What does the law already say about the right to health? And how can we ensure that in the way that we organize our health systems, the right to health remains the priority?
Due to our constitution, the international laws that we have ratified are part of our law. So every time we're mentioning the right to health, we're looking at the right to health not just as according to our constitution, but as according to the International Covenant on Economic, Social and Cultural Rights. And so when the committee of that covenant has a general comment that says this is what the right to health means, I can use that in court. And we've used it in court and said, look, listen, this is what the right to health means in terms of the ICESCR. That's what it means for us in Kenya because this is part of our law now. And we see it coming out in judgments. So we see judgments saying health means it has to be available, it has to be accessible, it has to be quality, it has to be appropriate. That's what we have seen by having a Bill of Rights framed in terms of an international human rights framework. Kenya has been able to use the international framework in a number of cases, including the Pumwani case, where there was maternal detention. So the case involved two women who had given birth and couldn't afford to pay the fees to give birth. And the hospital wouldn't let them leave, and they were kept in inhumane conditions. So not like detained and left in a bed and served food, no. On the floor because you're not allowed to sleep on the bed because you're not a patient anymore. Not given any food, but you can't leave. And being expected to breastfeed your newly born child, but you're not being fed. So for both women, it was for a period of around 8 to 14 days that they were detained. That's what came to court. The court's decision was just shocking that you would hold women after they gave birth when we have the right to health. And that was really the crux of the case. We have the right to health. And that means that it has to be affordable for everyone, not just some people. And when somebody has demonstrated an inability to pay, not an unwillingness, an inability, they can't afford the service. They require the service. Why would you detain them? And the court found that it was very cruel and inhumane to detain them and actually gave a judgment for the women to the amount of, I think it was 2 million shillings each in damages. They still haven't been able to recover it because recovering costs or damages from the state is quite difficult, but they did get a judgment in their favor. But what's painful is since that case have been other cases.
So strategic litigation is an important tool to build up the legal framework. But it is important to follow through and ensure that the policies are in place, but enforcement is also carried out, because without enforcement, then the litigation is good, but it ends up being just a piece of paper. To implement the judgments that come from the courts, you need to work with communities. And this is where civil society would sort of need to play that connecting role, because social movements oftentimes are very powerful instruments to sort of hold government to account, and civil society can connect them with the courts and use that as an additional strategy to put pressure on the government where they need pressure to move in the right direction.
If you look at our system, say 5 years ago and now, things keep improving, but with pressure. So we have a government that if you don't pressurize them, nothing happens. You put pressure, they do something. So that's how we're looking at it. Yeah.
So amidst all of this, we add a global pandemic.
I remember at the very beginning, there was a sense that we're safe because we're in a tropical country. There was some preparation, but I think the preparation was still optimistic. But as the numbers grew, then there was a sense of alarm at our preparedness.
The state was quite slow to move, and only mid-March after our first case did they now start implementing measures when we were already affected.
As we speak today, we have more people at home, receiving home-based care than we have in hospitals, because we still do not have enough, beds, for example, to manage the number of people who are getting sick.
The challenge also extended to people who had pre-existing conditions, and now because of the apprehension and the fear around the COVID pandemic and the lockdown measures as well, we had a lot of people who were hesitant to still visit hospitals.
The pandemic has kind of really exacerbated our problems as we speak today. So very many people are now out of work. Very many people cannot access medical health care. In that case, the cases that are not documented of people who are dying are very high in this country.
It has revealed a lot of the gaps that were in the system. Not that they weren't known, but they certainly have become more sharply in focus.
The healthcare workforce has been drastically affected. We had a series of strikes at the end of 2020 that came into 2021. All of the strikes were tied to the pandemic, the government's response, and their failure to protect the healthcare workforce through the response. We have seen a number of deaths, and because of that, some of our facilities have been overrun because we don't have healthcare workers. Frontline workers have been becoming ill. Some have even been forced to work while they were ill, forced to attend to people with COVID while they had COVID themselves because of a shortage of staff. And in the course of this, the government actually took time out to vilify the nurses. Some of the significant issues that they were raising was a lack of PPEs, a lack of health insurance, a lack of any measures for occupational safety and hazard. Government entered into negotiations with the doctors as early as possible and started to meet some of the demands that the doctors were making, but then didn't do the same with the nurses, and then went on a campaign to vilify nurses for refusing to go back to work. In the last year, we've had a series of scandals, so to speak, around corruption in governance and poor governance, particularly with the funding that has been provided for the management of the pandemic.
This money has been ending up in people's pockets as we speak today. The safeguards in terms of corruption were actually relaxed, so that then there is more freedom and then there is more flexibility in terms of being able to respond very fast. So while that is essential, it has actually not been used in the right way, because people then have used that window to accumulate as much as they can.
And this resulted in Parliament looking into it through a committee and requiring that the individuals who'd been highlighted were prosecuted, and even resulted in the president stating that they have to be prosecuted with absolutely no prosecutions. Like none. What we have seen is at least a little bit of an increase in the executive's will to address corruption. So the statement that was made by the president on the COVID millionaires isn't a statement we would have heard 2 years ago. And so at least based on that, we can hope that we will see an improvement in the next year and a half. I wouldn't say it has been completely deprioritized, but it's been highly deprioritized. I don't even think I've heard from the national government the phrase UHC in the last year. And it was one of the priority things to do by the end of 2022.
In essence, from a civil society perspective, it failed. because as we speak today, it's no longer continuing. Some of those counties decided to even drop it because they couldn't access funds to continue rolling it out.
When we spoke last, Makueni County, outside of the pilot, was really running its own universal health coverage. So what I will say is for Makueni County, which already had its own process ongoing based on its own initiative, they've fared much better within the pandemic in that they were the first county and still the only county to establish a shelter and a safe house for victims of violence. And then also they have fairly low numbers of infection despite neighboring a county that is high in positivity. And are able to put ICU beds in place much earlier than other persons. We're able to ensure the availability of oxygen much earlier than other counties, but they're not part of the pilot. That was just their own initiative that has been going on even prior to the pilot. Now the counties within the pilot, Kisumu is the only county of the pilot counties that actually put a directive in place to manage the pandemic outside of what was happening with the national government. All the other counties were either just adopting what was happening nationally, not trying to localize it, not trying to contextualize it, or not doing anything, despite being part of the pilot, despite having more resources towards health within those counties. One of the things that Makueni did in terms of health financing was create their own health financing mechanism that applies outside of the formal employment system. Only 30% of Kenyans are within formal employment. So then with that, they expanded accessibility because then it wasn't tied to employment. You just needed to have the amount of money and be able to pay it. So then they put in place a healthcare financing system that was much more inclusive than any we'd ever seen in the country before. If the county then committed to documenting their process and how they're able to do and what they're able to achieve through that, and that can be utilized as then a model to guide other counties in getting there. So I think what's been difficult for most counties is the how. Without the technical support, they haven't been able to figure out the how, and the national government hasn't done much to help them in getting to the how of how to get to UHC.
So a lot of the traditional civil society approaches to advocacy have had to be adjusted. With the lockdown measures, with just the way that COVID-19 spreads, community engagement had to take a hit.
So that kind of has a little bit slowed down movement building and local community actions. And obviously, in terms of us then being able to continue to hold the government to account. We can't even do processions, gather and present petitions to government. We can no longer do that now. And it has slowed down our momentum in terms of trying to push for good governance as well.
But we've seen organizations quickly adjust and find other ways of bringing community together. So, social distancing measures, utilizing digital technology more. So there are organizations that will, for instance, send out data to community members so that they have access to the internet and they can tune in for a joint discussion.
Going into online engagement became a useful tool, but then that also excludes so many of the communities that we work with that don't have access to online tools quite as easily. So what we've done is we've entered into quite a few new partnerships that we can ensure that the work continues with community-based organizations in different parts of the country so that they can actually work with us, where we can join virtually and they can hold meetings physically where it's possible, and we can just have this hybrid system whereby the communities who can't engage virtually are still engaged. Then that would then mean these partnerships became more important in that we were able to still reach communities, albeit not in person. And also the importance became relevant because then we were able to have skills transfer and sharing of knowledge, sharing of information, and facilitating the growth of other organizations outside of ourselves, which then we now foresee this as a future strategy that we're going to go with in terms of, rather than wanting to be everywhere, let's see how we can partner with people to ensure that we have the type of work that we do happening with other people everywhere. I think the first thing that we were very keen on doing at the beginning of the pandemic was work across sectors, work across stakeholders. So then we didn't limit ourselves to health rights activists or people who work on the right to health. We started conversations with people who work on governance, on transparency, on many other aspects, on child protection, on social welfare as early as possible, to at least provide input, meaningful input into the pandemic. We had to think broader than health services or health, and largely government and governance. And that was a good entry point for us. So then we were able to bring together what we call the COVID-19 Rights-Based Advisory Group, which has over 60 organizations and individuals across sectors. This included unions, professional associations, governance, NGOs, individuals, grassroots movements, among others, to really start the conversations based on the multiple issues we could foresee and our existing expertise. From the Women and Girls Subcommittee, we had a storm of Twitter chats throughout 2019, really focusing on SRHR being an essential service and pushing the government not to deprioritize SRHR because of the pandemic. From the Children's Subcommittee, we saw them participate in the development of a child protection policy in the course of the pandemic and putting out guidelines for child protection during the pandemic. We saw from the Rule of Law Subcommittee of the COVID-19 RBA, we have 4 cases that have come out of that. In that, 4 cases have gone to court. What has been initiated against the government and various state actors in how they manage the pandemic response. Because the executive was passing regulations, public orders, in absence of parliamentary oversight, which then meant the only recourse they had was the court, which became very useful. And we've seen a flood of cases, PIL cases from different parties.
The international frameworks and institutions that we had discussed earlier are still crucial allies in this advocacy process. A lot of them have already put out statements to just affirm their position on how states should be responding to the crisis, the discussion on vaccine access and vaccine equity and a people's vaccine. These statements from human rights bodies and human rights experts can be very helpful tools for civil society. There's been a lot of litigation, for example, litigation challenging states on the approaches that they take in the response to the pandemic, in the response to the impacts of the pandemic. And civil society has a unique opportunity here to incorporate the human rights statements from these bodies of experts, from the treaty bodies and so forth, so that the courts can first be guided themselves, and then in so doing, incorporating their judgments as they advise governments, as they direct governments where they do, how they should be guided by the statements made by the human rights experts. So one thing that has stood out, of course, is the vulnerability of systems that rely too much on private actors, for instance. The sort of organization, the sort of coordination that was required to respond to the COVID-19 pandemic, the sort of subsidizing that needed to be done, the reach that needed to happen for us to effectively respond to the COVID-19 pandemic is something that's primarily, I dare say, only possible through governments. The government is the one that has the capacity, government is the one that has the reach, government is the one that has the obligation, and is therefore better placed to respond as fast as is required to be able to mitigate the impact of a crisis. We saw private actors actually turning to the state for bailouts, for subsidies themselves, and this shows that a lot of things also are being debunked. There was an assumption that resources are primarily held in private hands, in private actors, and that they have to step in to help. But the COVID pandemic has sort of flipped that narrative and shown that it's states that have the resources and the capacity. And it's important for them to take the lead, while of course private actors can supplement and enhance the work that the state is doing. The public health insurance, where it exists, the coverage is still very small. A lot of people rely on private medical providers. But one thing that stood out when the pandemic hit is that many of these companies have an exclusion clause for pandemics. So they instantly say that now they can't cover anyone who will test positive for COVID-19. And that's a concern, first, again, demonstrating the risk of over-reliance on private sector, particularly commercial private sector, but also the importance of effective state regulation where the private actors do operate, because there's some instances where the regulations need to be designed in a way that upholds the principles of the right to health. There's an appetite to prioritize UHC and scale it up and roll it out and ensure that everybody is covered. But this sort of runs up against the reality that COVID-19 has also dealt a heavy blow on the economy.
It's going to be a difficult situation, obviously, for a couple of years from my end and from my thinking, because one, it requires resources for you to be able to implement an effective and robust, very responsive healthcare system in terms of UHC. So right now we are in a debt crisis as a country, and I do not think we are going to, get enough resources to spend on UHC.
Things have to change, and it is urgent that things are changed for the society, for the country, for the region to be able to withstand the shocks. Because while right now our main focus is on the COVID-19 pandemic, it's also true that there are other crises that we are in the middle of, like the climate crisis. And a lot of experts and scientists and environmentalists predict multiple waves of crises. So it's urgent and imperative that governments change the way that things have been done so far, that governments are incorporating the human rights framework not as an option, not as one of the tools that they may or may not refer to, but as the fundamental underpinning framework for whatever policies they design.
So if that becomes the new thinking, by 2030, we could be at a good place to say, yeah, our healthcare system has really improved. But if our thinking is that we are only tackling the pandemic, and at the end of the pandemic, we go back to where we were, then definitely we are not going to move and we are not going to achieve the Agenda 2030.
We need to focus on rights, because we won't get there if we don't.